Great. Thank you so much for inviting me to speak at this conference. I'm really excited to share some of the work I've been doing, but also just review how to optimize nutrition for infants with congenital heart disease. Giving them a good start in life is very important for long-term outcomes. So thank you so much for having me. So my financial disclosures, I have nothing significant to disclose. I am on the Speakers Bureau for both Prolacta and Medela. So what I hope to cover in this talk is I'd like to review a little bit of the embryology of congenital heart disease, and then review malnutrition in infants with congenital heart disease and what encompasses that, and then how we can optimize nutrition both pre and post-operatively. So congenital heart disease is the most common congenital anomaly occurring in around 10% of live births worldwide. And about 25% of these infants have a type of critical congenital heart disease that requires some type of surgery. In 2015, almost 49 million people globally had some type of congenital heart disease. So this is a worldwide issue. And this occurs when the heart doesn't develop normally in utero. So this is just a brief review. I won't go over into too much detail about the embryology, but this begins with the formation of two endocardial tubes, which merge to form the tubular heart, also called the primitive heart tube. The heart is the first functional organ in vertebrate embryos. The tubular heart quickly differentiates into the truncus arteriosus, the bulbus cordis, the primitive atrium, and the sinus venosus. The truncus arteriosus then splits into the ascending aorta and the pulmonary trunk, and the bulbus cordis forms part of the ventricles. The sinus venosus then connects to the fetal circulation, and as the heart tube elongates to the right side, looping and becoming the first visual sign of the left-right asymmetry, the septi then also form within the atria and ventricles to separate the left and right sides of the heart. So you can imagine this is a very complex process and lots of opportunities for things to go wrong. This is just a very brief review of some of the key regulators that help the growth and differentiation of the cardiomyocytes into the different parts of the heart. And you can imagine with this number of different regulators and different stages of heart development that oftentimes things can go wrong and lead to congenital heart defects. So the congenital heart defects are often divided into acyanotic and cyanotic lesions. So in the acyanotic lesions, you have two different types, those that increase pulmonary blood flow, like atrial septal defects, ventricular septal defects, patent ductus arteriosus, and AV canals. You also have obstruction to blood flow from the ventricles, so those would be things like the coarctation of the aorta, aortic stenosis, or pulmonary stenosis. And then you have the cyanotic lesions, and these can also be divided into two main categories. So when you have those that decrease pulmonary blood flow, so those would be things like tetralogy of Fallot or tricuspid atresia. And then you have those with mixed blood flow, so transposition of the great arteries, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. So what are some potential causes of congenital heart disease other than what I had mentioned before during formation with all of those different genes and key regulators? So sometimes changes or mutations in DNA can be responsible for the development of a congenital heart defect. About 15% of these defects are linked to genetic or chromosomal conditions. So such things as trisomy 21, Noonan syndrome, or Turner syndrome are examples. It's rarely due to inherited genes from parents, so that's important to when we counsel parents, it's important to let them know that it's not a result of their genes. So other factors that can increase the risk for development of a congenital heart defect in the fetus are maternal medical conditions like lupus, phenylketonuria, obesity, and diabetes before becoming pregnant, not gestational diabetes. Medications that the mom may be taking, like ACE inhibitors, isoretinoin, lithium, statins, and thalidomide, have all been associated with the development of heart disease in the fetus. And then some viral infections like rubella, if it's contracted within the first 3 months of pregnancy, can lead to this, because again, that's when most of the development of the heart is taking place. So what is the overall prognosis for infants that have a congenital heart defect? And most of it really depends on the presence of comorbidities, obviously, as well as the type of heart defect that they have, and the gestational age at which they're born. So we have some preterm infants who are born, at 24, 26 weeks. They're going to have a very different prognosis than a term infant. And also optimizing the nutrition for these babies, both pre and post-operatively, can have a significant impact on long-term outcomes. So some of the comorbidities that prevent optimal nutrition in these infants are gastrointestinal issues, so things like reflux, dysmotility, anatomic malformations. Sometimes these are midline defects, and so they will have renal, GI, and cardiac malformations as part of a syndrome. Some medications can prevent that. So if they need to be on prostaglandins or they need to be on hemodynamic support like epinephrine or dopamine. And other contributors to malnutrition are the increase in sympathetic activity, the increased work of breathing, and presence of congestive heart failure. These can all lead to an increased metabolic demand in these infants, and therefore we need to make sure that we are giving them enough calories and nutrition to provide them with what they need. Genetic syndromes have been associated with abnormal growth. So trisomy 21, Turner's, and DeGeorge are some common ones that we see that have heart defects, and they're known to have poor growth just because of their genetic defects. So pulmonary arterial hypertension, or PAH, has a strong association with preoperative malnutrition. And the underlying mechanism is mainly related to the hypoxia-induced adaptive responses and increased pulmonary blood flow. And what this does is lead to endothelial dysfunction and vascular remodeling, and that leads to progressively higher pulmonary vascular resistance. And over time, this feed-forward pathway really causes disruption and increased metabolic demand in these infants. So pulmonary hypertension causes this right ventricular failure. That in turn leads to gastrointestinal edema and malabsorption and altered microbiome, as well as fluid retention. So often these kids are given diuretics to help prevent some of this excessive fluid retention, but diuretics also have side effects, one of which being B1 deficiency. And this is an important micronutrient that it's involved in carbohydrate and branch chain amino acid metabolism. So what are some potential outcomes when these babies don't get optimal nutrition? So most of these infants are born appropriate for gestational age. So they're grown well in utero and they come out, and what happens is with poor nutrition after birth, they develop malnutrition in the first few months of life. About 21 to 29% of these develop moderate malnutrition. So what exactly are we saying is malnutrition? It's really a result of inadequate energy intake or an increase in energy expenditure, resulting in an energy imbalance. And during critical illness, which most of these congenital heart defect kids are at, studies have suggested that energy requirements have an increase up to 30% in mild illness and 50% in moderate to severe stress in these infants. So it's really important to gauge how critical these infants are and how much extra nutrition they're needing above baseline. So infants with congenital heart disease, as I mentioned before, have an increase in metabolic demands, possibly from the increased work of breathing, the pulmonary arterial hypertension, and congestive heart failure. So these infants who are critically ill may need up to 50% more energy to maintain an adequate weight gain. And again, this is all individualized based on how severe the infant is affected from their heart disease. So in addition to just issues with weight gain, malnutrition can also delay wound healing. So postoperatively, when they have an open sternotomy, that can be a problem. They can lead to myocardial dysfunction. It can increase vascular endothelial damage and cause decreased muscular function. So this really overall leads to increased risk for postoperative complications and infections. So really optimizing nutrition in the first 12 months is crucial to making sure that these infants grow and develop appropriately. And this first year of life is very critical to that time period. So infants who experience growth failure during this time have an increased risk for long-term cognitive deficiencies like attention deficit hyperactivity disorder, forms of aggressive behavior, and poor social and emotional development. And failure to thrive is more common in infants with congenital heart disease than non-heart disease infants for all the reasons that I've mentioned before. So how can we optimize nutrition for these infants? There's really not a lot of literature on how to provide good nutrition. Most guidelines and protocols are based on observational or retrospective studies, and these have the limitation of non-standard criteria for assessing the needs in each case. Some of them have specialized equipment to be able to assess their resting energy expenditure. If they're in a very sophisticated hospital, others go based on the criteria needing moderate or severe illness. So you really have to individualize the nutrition for each infant based on their current status. So newborns with these abnormalities have difficulty initiating and sustaining an efficient enteral diet, both due to a waste of energy and to neurological, motor, gastrointestinal, endocrine, and renal developmental problems. And these all increase their metabolic needs. So we also want to make sure that for assessing their fluid requirements, which can be difficult, we want to make sure that we're looking at all the contributors to their fluid status. So it might be based on what medications, like vasoactive medications or diuretic medications that they're on. And we want to make sure we maintain an appropriate balance between the diet, the enteral diet that they're taking, and the parenteral nutrition that they're receiving through IV. It's important to make sure that this fluid balance is in a good state in terms of the functioning of their heart. So kids who have a malfunctioning heart may need less fluid and a higher concentration of nutrition to be able to, for their heart to be able to handle it. So we discussed a little bit before that infants with congenital heart disease have increased metabolic demand, and this can be due to increased resting energy expenditure, a higher cardiac workload, pulmonary arterial hypertension that we mentioned before, and this increased catecholamine secretion that these infants often have. In addition, the diuretics that they are often on can lead to electrolyte and mineral imbalances, so like hyponatremia, hypochloremia, metabolic alkalosis. These can all lead to anorexia, poor weight gain, and impaired wound healing. So in terms of preoperative nutrition, what is our goals for these critically ill infants? We want to make sure that we provide sufficient dietary protein to make sure that the infants can adequately produce protein, to make sure that they have enough resources in their body to facilitate wound healing, to modulate inflammatory responses, and to preserve their skeletal muscle mass. So ideal nutrition in these infants, as we all know, breast milk is one of the most important sources of ideal nutrition for any infant, but particularly in infants with critical illness. So it has nutritional and immunological benefits, as well as interpersonal benefits. It allows for mother and babies to bond during breastfeeding. However, the specific data on benefits of breast milk for congenital heart disease infants is scarce, but it's reasonable to assume that given the benefits of breast milk that we know, that these infants who have vulnerable GI systems could be helped in terms of GI function, immune maturation, and feeding tolerance, and microbiota composition if they are fed breast milk. And we assume this because there's a lot of data in preterm infants about exclusive human milk and the benefits that it gives to the preemies, specifically with the reduction for necrotizing enterocolitis. And so we can extrapolate that these same benefits in preemies would apply to our term infants with congenital heart disease. However, breast milk alone may not be enough for infants with these diseases because of the increased metabolic demand. And so often the caloric needs are higher than breast milk, which only has 20 calories per ounce. We need more randomized trials to look at providing ideal nutrition. There really just isn't a lot out there to be able to guide most centers on how and what needs there are for these infants. So the research that is out there shows that breastfeeding can be an option. However, there is concerns regarding the energy expenditure that it takes to do actual breastfeeding. So the suggestion in the literature is to reduce the frequency and duration of feeding so that we limit the feeding to a maximum of 30 minutes per feeding episode to try to reduce calorie expenditure. We also want to make sure that we're looking at how we're preparing breast milk with the fortification to make sure that we're not over diluting it or providing an excessive concentration, both of which can result in poor growth, electrolyte imbalance, and gastrointestinal impairment. So we do know from some of the literature that's out there is that early initiation of trophic feeds has been shown in studies to be safe and well tolerated. There's some suggestion that it's associated with shorter duration of ventilation in these infants, and also a trend towards more stable postoperatively hemodynamic course. They tend to have less fluid overload and are have a shorter time to reach full enteral feeds after surgery. So this literature that's out there does support feeding prior to surgery and making sure that we encourage moms to pump to give some of this breast milk beforehand will impact the post-surgical outcomes. So about half of the European centers avoid enteral feeding in infants with congenital heart disease due to concerns of potential GI complications and splanchnic ischemia, especially with regard to single ventricle physiology like hypoplastic left heart. Something called necrotizing enterocolitis is a big concern for these infants in terms of providing enteral nutrition. So some centers have developed specific feeding protocols for these infants due to these concerns. The Pediatric Heart Network investigators reported recently that impaired feeding and growth were significant predictors of adverse neurodevelopmental outcomes, specifically in the hypoplastic left heart syndrome kids. And another study by Toms et al. Looked at trophic feeding, about 20 mils to 30 mils per kilo per day in these infants, and found no difference in adverse outcomes between those that were fed preoperatively and those that were not. They did find a significant difference between the two groups related to fluid balance and decreased duration of ventilation post-op, which just goes to support the idea that it is imperative to give these infants some type of enteral nutrition to try to promote all of the important benefits that breast milk has in terms of GI maturation and the immunological benefits. So in 2020, the European Society for Pediatric and Neonatal Intensive Care published their recommendations on nutritional support for all children during critical illness, but they did specifically look at kids with congenital heart disease, and they recommended starting feeds within 24 hours and hemodynamically stable neonates with or without cardiovascular support. Some of the potential contraindications they listed, however, were those infants who had a GI anatomic abnormality that would prevent someone from giving enteral nutrition, if they had any maxillofacial abnormalities, if they had increased abdominal girth suggestive of a GI process, if they had excessive vomiting or diarrhea, they had a positive fecal occult blood, or signs of necrotizing enterocolitis, or signs of lactic acidosis. They overall supported giving enteral feeds even if there was an umbilical arterial catheter in place, as well as if the infant was receiving prostaglandins infusions. Both of those had traditionally been contraindications in the neonatal world to providing enteral nutrition. So for those that aren't familiar with necrotizing enterocolitis, it's a more common condition in preterm infants, but it has an increased risk in infants with hypoplastic left heart syndrome. It usually presents in term infants, in congenital heart disease infants within the first 7 days, versus in preterm infants, we typically see this around 2 to 4 weeks of age. We don't have an exact etiology for the cause of necrotizing enterocolitis, and it's likely multifactorial. However, recent literature has suggested that an exclusive human milk diet does decrease the risk in our preterm infants for the development of NEC. And so is there a potential source of inflammation from a non-human protein that is found in formula as one of the causes of this? So again, with infants with congenital heart disease, that's one of the reasons why we initially prefer to feed these babies breast milk. So there is a reported up to 11% risk for developing necrotizing enterocolitis, specifically in the hypoplastic left heart syndrome infants, which again is one of the reasons why providers have concerns feeding these single ventricle physiology patients. So I've talked about this a little bit before, but it's really hard to determine the exact caloric requirements for each infant due to differing metabolic demands. Again, the hemodynamic status, what other anatomic abnormalities they have, what kind of medications they're requiring, those all play a role in their the caloric needs for each infant. A study by Luca and colleagues recommended that a term ill newborn needs approximately 40 to 60 milliliters per kilo per day, with a gradual increase to 90 mils per to 120 mils per kilo per day of IV nutrition or enteral nutrition. But term infants with congenital heart disease, especially those who are moderate to severely ill, may need up to 50% higher daily caloric goal, with up to 150 mils per kilo per day of volume and at least 3 grams per kilo per day of protein due to the increased requirements for normal growth. So in terms of protein, protein loss is frequently associated with congenital heart disease, especially following surgery. So it's really important to pay attention to optimizing protein in these infants. Protein is needed for tissue repair, for regular growth, for wound healing. It helps to modulate inflammatory responses and preserve skeletal muscle mass. There's a minimum requirement that's recommended by both the European and American guidelines to prevent a negative balance. But really, in these congenital heart disease infants, providing about 3 grams per kilo per day should be given in infants who are less than 2 years old. And in our preterm population, we target 4 grams per kilo per day. In terms of glucose intake, parenteral glucose intake using a 10% glucose solution is preferred. A minimum of 2.5 mg per kilo per minute in the acute phase and up to 5 mg per kilo per minute in the recovery phase. But again, this is all dependent and individualized on each infant. By monitoring the glucose levels in the blood, you can adjust your glucose infusion rate to meet optimal requirements. In terms of lipids, we try not to exceed 3 grams per kilo per day, and we adjust this amount by monitoring triglyceride levels in the blood. We want to give at least 0.5 milligrams per kilo per day to prevent any lipid deficiency. And one of the things that we're more recently focusing on is the composition of lipid emulsions. There are some better options to make sure that we provide more omega-3 fatty acids compared to omega-6 fatty acids. Omega-3 fatty acids are known to be more anti-inflammatory versus omega-6 that have more of a pro-inflammatory component. And so for infants who are expected to be on long-term IV nutrition, providing different lipid emulsions could help prevent some of the cholestasis and liver dysfunction that we see in these infants on prolonged IV nutrition. So if we have to use formulas or we use formulas to fortify the breast milk, we want to make sure that they are rich in protein and energy to make sure that we're optimizing the nutrition that we're giving these infants. We want to be careful of the osmotic load of formulas to make sure they don't exceed 450 milliosmoles per kilo of water. And we want to make sure that for infants who have an intolerance or potentially a chylothorax, that we're using an appropriate formula for that infant. So some of these infants require a hydrolyzed peptide formulation or a medium chain formulation in the case of chylothorax. So some medications that these infants are on can alter the ability to provide adequate nutrition. So usually these infants are on some type of pharmacological medication to work to manage their renal dysfunction, if they have any issues with hypertension, or if their cardiac function is not optimal. In addition, almost all of them are on diuretics, and as I mentioned before, this can modify the electrolyte profile. So we have to make sure that we're monitoring these electrolytes carefully and making sure that we keep everything in balance based on our enteral and IV nutrition formulations. So in terms of parenteral nutrition, you want to make sure that you start early, right after delivery. So hopefully on day of life 1, start with at least 2 grams per kilo of protein and at least a half to 1 gram per kilo of fat, depending on the baby's tolerance. And again, as I mentioned, we want to start lipids immediately to prevent fatty acid deficiency, and you want to start protein immediately to prevent protein catabolism. We want to make sure that we're advancing our parenteral nutrition daily, ideally reaching a glucose infusion rate of 12 to 14 milligrams per kilo per hour. A protein we mentioned before, 3 grams per kilo per day in term infants and 4 grams per kilo per day in preterm infants. And optimizing fat intake, usually 2 to 3 grams per kilo per day in both term and preterm infants. Ideally, calorie ranges are 100 to 130 kcals per kilo per day in term infants and 120 to 140 kcals per kilo per day in preterm infants. But again, there's a range there because depending on the how severely ill the baby is will depend on the calorie needs. So in the NICU, we use the birth weight for the first 7 days of age to prevent inappropriate weight loss. So about 10% we expect loss in regular term infants and about 15% in preterm. So we want to make sure that we're not using that appropriate weight loss as their actual weight. So once they surpass their birth weight, then we start using that as their weight to determine caloric needs and fluid requirements. If a patient is edematous, we do try to use a dry weight, and we can estimate that based on using a growth curve using the appropriate weight for length or the 50th percentile, typically using the preterm Fenton curve in our unit. We want to make sure we use concentrated glucose solutions for drip medications, such as pressors, to minimize fluid overload from non-nutritive sources. And we also want to make sure that we can concentrate some of our parenteral nutrition substrates as much as possible, again, to decrease the excessive fluid intake from non-nutritive sources. So in terms of enteral nutrition, ideally, we'd love to give enteral nutrition 10 to 20 mils per kilo per day, starting right after birth. And as we know, the European Society for Pediatric and Neonatal Intensive Care did recommend this and support this. Ideally, we'd love to start with breast milk or donor milk if that's available, and then secondarily formula if that's the only option. It has been shown to be safe and well tolerated, even in patients on prostaglandins and with shunts, as well as infants with umbilical arterial catheters in place. Men or minimal enteral nutrition is typically not included in the caloric goals, which may be up to 145 to 150 kcals per kilo per day in patients with some type of heart defect. Although rapid advancement in caloric density has been associated with favorable weight gain, the risk of neck may be increased, particularly in the preterm population and those with single ventricle physiology. So it's more appropriate to advance feeds in a smaller and slower fashion by 20 mLs per kilo per day. You want to pay close attention for feeding intolerance, abdominal distension, residuals, and bloody stools, as this could be a sign that there is the development of some type of GI abnormality, and specifically necrotizing enterocolitis. There are varying protocols when increasing caloric density. Some suggest holding feeds at 100 mils per kilo per day while increasing caloric density stepwise to 24 to 27 kcals per ounce, and then advancing to full volume. Other places will advance calories and volume at the same time. There really hasn't been anything published to standardize a method to do this, specifically with randomized trials, so that is definitely something that's needed in the future. We do in our unit advocate fortification. Currently, we're using a human milk-based fortifier to continue an exclusive human milk diet at our infants most at risk. And so far, we've had good success in tolerance and decreased rates for necrotizing enterocolitis. You want to make sure as you're increasing your volume and calories of your enteral nutrition that you're weaning your parenteral nutrition stepwise to maintain your overall daily caloric intake, as well as making sure that you maintain your goal protein and fat intake. And you continue to monitor electrolytes as well as triglycerides to ensure that you have a good balance. You want to discontinue your parenteral nutrition as soon as possible, but only after achieving an adequate enteral intake, including caloric intake. So It's important to plot at least weekly the weight, length, and head circumference to assess for adequacy of nutritional intake. And again, some units have more sophisticated ways to measure things. Most units will use these curves and assess these parameters weekly. You can also use your blood labs like blood urea nitrogen, albumin, prealbumin, calcium, phosphorus, and alkaline phosphatase levels as markers of nutritional status. And again, you're looking at the overall growth over time. And so if you start to see some drop-offs, it's important to work with your dietitian and the unit to figure out where you can optimize your protein and calories to make sure that the babies don't fall too far off their curve. So in terms of postoperative nutrition, malnutrition is relatively common postoperatively, and this is due to several things, mostly because these babies are on multiple medications for hemodynamic status reasons. They're usually ventilated, they have some degree of renal impairment, and they have the open sternotomy, and some of these have developed chylothorax as a result of the surgery that they needed. So here is a diagram. It just highlights some of the many challenges that these infants with congenital heart disease face that could impact their nutritional status. So there's an increased incidence of oral feeding difficulties, and up to 45% of congenital heart disease infants do require some type of NG or G tube at discharge due to these issues. You can have you can have GI malabsorption, you can have vocal cord dysfunction, dysphagia. All of those are helped with adequate support over time. They can have oral aversion due to prolonged mechanical ventilation. They can have neurologic injury from their cardiac defect and potentially from the surgery that they needed, and going on bypass sometimes can lead to adverse outcomes. So Singhal et al. Performed a systematic review and meta-analysis on postoperative nutrition in infants who had undergone surgical repair for congenital heart disease. And they found that infants who were fed standard feeds of breast milk or term formula were malnourished and unable to meet the protein and energy intake necessary to achieve adequate weight gain. The infants in the intervention group were given feeds that were fortified to optimize protein and energy. And this was shown to improve overall postoperative outcomes. So overall, the feeding protocols were different in the trials that they reviewed, but the meta-analysis that they performed did suggest that fortified feeds were important for infants with congenital heart disease in terms of improving overall outcomes. But it did say that more trials with evidence-based feeding practices are needed to confirm. Oops. Sorry. There's also some studies that suggest that these fortified feeds that these infants are given show a decreased length of ventilator days, a decreased length of stay in the hospital, both in the ICU and in the overall hospital length of stay. Studies that looked at studies that looked at early initiation of enteral feeds postoperatively was found to be safe and feasible. And these were feeds that were initiated within 6 to 24 hours postoperatively. So a survey of European PICUs, 59 PICUs from 18 European countries responded to the survey. Less than 60% of the units had a dedicated dietitian. And infants with congenital heart disease were routinely fed preoperatively in only 63% of these PICUs. And most of that was due to the ongoing concerns around prostaglandin infusion and the presence of umbilical or arterial catheters, as well as the use of vasoactive drugs. About 76% of infants were routinely fed during the first 24 hours postoperatively. And the most common feeding method, both pre and postoperatively, was intermittent bolus feeds via an NG. About 69% of European PICUs still did not have written guidelines for feeding. And this really emphasizes the need for more standardized methods of feeding these infants in order to have outcomes that we can measure across the world. So in terms of discharge nutrition, There are several approaches to post-discharge nutrition. You want to allow short feeding times to try to decrease the risk for oral aversion, and then provide the rest via G-tube or provide continuous feeds via an NG or G-tube. But often these infants have developed severe feeding aversion, again, to prolong mechanical ventilation. So it's important to work with speech therapy as well as other providers to optimize their outcomes by working with the oral motor coordination and prevent some of this aversion. A study by Shine had found that 52% of infants post-stage 1 repair for a univentricular circulation went home with enteral tube feedings. So again, if we can try to minimize some of these outcomes by early initiation of enteral feeds and early work with oral motor stimulation, potentially we can decrease this rate. So we also want to make sure that we follow these infants closely post-discharge from the NICU or PICU. They can develop chronic malnutrition, and this can result in stunting of growth, increased risk for poor neurodevelopmental outcomes, and an increased risk for social and emotional issues. And this is especially true for infants who require multiple surgeries to repair their type of congenital heart defects. So in conclusion, it's imperative to optimize nutrition in infants with congenital heart disease at every stage in order to optimize both short and long-term outcomes. So I want to thank you for your attention, and if anyone has any questions, I'd be happy to take them.